Hi, my name is Carmen Isringhausen. I'm a DNP student at Maryville University. This is my presentation over my project Implementation of Structured Shift Huddles to Target Discussion of Chlorhexidine Gluconate Bathing Compliance. My committee members were Dr. Maria Snell, she's my chairperson, and my community member was Sharon Bush. The aim of this project was to increase daily chlorhexidine gluconate, or CHG, bathing to a goal of 90% daily compliance by implementing a structured shift huddle. There was a secondary aim to the project to decrease incidence of central line associated bloodstream infections, or CLABSI, and also catheter associated urinary tract infections, or CAUTI. This would only be looking at hospital acquired occurrences. The study took place on an inpatient acute care medicine floor, which was identified as having daily CHG bathing compliance rates at about 60%. This project was of personal interest to me because at the time of the needs assessment and that I was beginning to think about my DNP project, I was employed as a nurse on this floor. So I was one of the nurses that was working to be responsible for bathing our patients daily with CHG. And so I felt that I also had a responsibility or a role in these low compliance rates, and therefore I wanted to attempt to make my workplace better, and that is how this DNP project was created. The structured shift huddle was supported by literature that showed that increased staff focus on CHG bathing was proven to decrease rates of CLABSI and CAUTI. There also was a concern about the hospital-acquired infections, which can increase mortality of patients. It increases the cost to patients, and it increases the cost to the hospital as well. Every CLABSI is estimated to cost about $45,812, and CAUTIs are estimated to cost at about $896. Advanced practice nurse leadership skills are important to have during DNP project research and formation. They're necessary for identifying needs, setting the aims of the project, setting the expectations of the projects. There's coordination involved of team members, and there is a policy development element. Nurses were important to this study because they were responsible for bathing their patients daily with CHG unless contraindicated, and the heat maps that were used to pull the data from the facility's database about the CHG bathing were dependent on documentation that was completed by the nurses during their shift. Increased bathing compliance has been shown to decrease the risk of infection, so our secondary aim was based on that. And huddles increase communication, teamwork, and awareness. There was also a bi-daily huddle already in place, so we utilized part of that workflow that was already established to help with our intervention, or my intervention. A review of the literature specifically around structured communication. Communication creates known standards and expectations, and it's shown to increase the efficiency of work. Increased communication has been shown to increase CHG bathing compliance, and structured shift huddles provide a forum for correct information, guides information, sets goals, and allows for discussion and feedback between those that lead the shift huddle and those that attend the shift huddle. A review of literature specifically about infection prevention showed that daily CHG bathing is recommended by the Centers for Disease Control and Prevention, or the CDC, and increased CHG bathing decreases occurrence of hospital-acquired CLABSI and CAUTI. The theoretical framework behind my project was Tuckman's stages of group development. The first stage of this is creating a group of individuals, setting boundaries and identifying a goal for the group, and collecting associated information. The second step is anticipating that the group is going to have some conflict as individuals seek to find personal success within that group for those goals. The third step is recognition that there's a benefit to focusing on individual effort to achieve that group goal as a team. The fourth step is acting on the group goals set in the beginning to achieve success. So this would be completing the project and striving for those aims. The fifth step is after the completion of goals or after a project ends, members will leave that group, but they will return for advice and recommendations. This related to my project. Lack of CHD bathing compliance was discussed during the project needs assessment, so we were collecting the information, setting these goals of the daily CHD compliance rates of 90%, and identifying that our group to focus on would be the acute care medicine unit. There's conflict occurring in the form of barriers during the shift. This can vary day to day, whether that is conflicts personally for the nurse or there are external conflicts with patients or system failures. The third step related to the importance of communication and cooperation becoming apparent as nurses can also view these CHD daily heat maps. They're also displayed during the nursing staff's monthly shift or monthly staff meetings. The fifth step would be after the completion of the project. There would be discussion with colleagues concerning results and implications from the project. Methods and design of the project. This was a pre-post design with a retrospective chart review. Pre-intervention data started in January 1st, 2023 to January 31st, 2023. The shift huddles, structured shift huddles began on February 1st. So our post-intervention data collection was from February 1st, 2023 to March 31st, 2023. We reviewed data that was collected after the implementation of the structured shift huddle, and this included data about CHD bathing compliance rates and also the rates of CLABSI and CAUDI. There were no formal shift huddle script prior to the study. The shift huddles are led by unit management, and they are a mandatory requirement before each incoming shift. So I implemented, with the help of unit leadership, the shift huddle script, which included the information: what patients received baths over the previous shift, what patients refused baths over the previous shift, what patients need a bath attempted during the incoming shift, and what possible barriers exist during the incoming shift that need addressed to achieve bathing of 90% of patients. CHD bathing data were collected via heat maps in the facilities database, and that reflected chart documentation done by the nurses each shift. CLABSI and CAUDI data reports were obtained from the floor's infection prevention specialist. And retrospectively reviewing results will help determine if the structured CHD bathing discussion at Huddle will increase CHD bathing and therefore decrease CLABSI and CAUDI data. The sample was made up of a convenience sample. It included the bathing opportunities of patients admitted to the acute care medicine floor from January 1st to 2023 to March 31st, 2023. We weren't counting individual patients because individual patients may have varying lengths of time of stay on the unit, so we wanted to count, the statistician and I during needs assessment wanted to count each individual opportunity for bathing, as that patient would have a bathing opportunity each day that they were admitted to the floor. There were 1,240 pre-intervention bathing opportunities, pre-structured shift huddle, and there were 2,210 post-intervention bathing opportunities included in the sample. The inclusion criteria and exclusion criteria pertains to whether I was able to examine data from the heat map concerning that patient's documentation about that patient's bathing status. So the inclusion criteria was to have documentation in the electronic medical record, or EMR, that the patient is 18 to 105 years of age. They needed to be on the unit for at least 24 hours, and they needed to not have a contraindication to being bathed with CHG. Exclusion criteria included documentation that the patient was under 18 years old, if they had a documented contraindication to being bathed with CHG, or if the participant was admitted or discharged during the calendar day that the data was collected. This went from midnight to 23:59. CHG data came from the heat maps. We specifically analyzed the number of bathing opportunities and the CHG baths completed. I wanted to show a rate of completion as our goal was 90% compliance. Ordinal data concerning CHG bathing compliance rates were analyzed with an upper tail z-test. My p-value ended up being 0.0965, and I compared rates of pre-intervention and post-intervention CHG bathing compliance. CLABSI and CAUTI data were not statistically analyzed, as both the pre-intervention data and the post-intervention data reported 0 hospital-acquired occurrences pertaining to that unit. My results, the sample size for the pre-intervention group was 1,240 patient bathing opportunities. During the time from January 1st to January 31st, 2023, there were 952 baths completed, which resulted in a compliance rate of 76.77%. After the structured shift huddle was implemented on February 1st, through March 31st, 2023, there were 2,210 patient bathing opportunities. During that data collection period, there were 1,739 baths completed, which resulted in a compliance rate of 78.69%. The results were analyzed with an upper tail z-test, and this revealed that there was not a statistically significant difference between the CHG bathing rates pre and post-intervention. The study established that a larger sample was needed to raise the power of the study, and so I needed more patient bathing opportunities, and to get more patient bathing opportunities, the data collection time period needed to be longer. Limitations to the study included the small sample size, a short study duration. There were also difficult to account for patient-related variables. There were differing lengths of stay on the floor. So if a patient was transferred in and out of the floor, that was included in the exclusion criteria, and their patient bathing opportunity would not be examined. There were also patients that may have been on the floor for an extended period of time, and if they were routinely refusing their CHG daily baths, then that would skew the data as far as the refusal affecting the number of baths being completed each day. There were also differing patient opinions on bathing versus refusing to bathe. Some patients may have just not felt like it at the time that they were asked. Some patients maybe don't bathe every day at home, so they didn't want to bathe every day when they were admitted in the hospital. As long as patients were making an educated decision and they had autonomy, we as nurses need to respect that the patient can choose to not be bathed, and so there would be a missed patient bathing opportunity. Patients also left the floor for varying reasons. They could be ambulatory, leave the floor on their own. They also could leave to go to a testing site or a procedure site or surgical site. Barriers to patients receiving baths also includes if they were receiving transfusions or dialysis. And so there were many factors that were out of control of myself, the nursing staff, and unit leadership. A longer study with larger sample sizes would also provide more diverse samples and make the study more generalizable. And the study could be strengthened with education for both staff and patients. Initial support for the targeted discussions from the literature review for increasing CHG bathing compliance with structured shift huddles made me hopeful. I expected to see a larger and more consistent increase with compliance with CHG bathing. There was a slight increase with the CHD bathing compliance after the structured shift huddle. It was 1.92%. Even with that increase, I was still at only 78, 79%, which was still not reaching that goal of 90% daily compliance. And I was unable to determine if the structured shift huddles would increase the CHD bathing enough to have an impact on the reports of CLABSI and CAUTI occurrences. Again, the pre-intervention and post-intervention rates were both 0% for both CLABSI and CAUTI for this unit. This project has implications for future research and future practice. It highlighted the need for education about CHD bathing for nursing staff, about how and when to use CHD soap, making sure that we're using it every day, making sure that the nurses know to bathe the patient from head to toe, that they're using the correct ratio of soap to water, that they're changing out their washcloths to make sure that they're bathing the patient in the most effective way possible, would have been an important part to add to this project to make sure that the baths were as consistent and as compliant as possible. Education is also important for patients. So like I mentioned, we were conscious of making sure that if they refused a bath, we respected that wish, but it's important to make sure that the patient is making an educated decision about their care. It's also important to understand that some of these patients were independent with their activities of daily living, and therefore they'd be giving themselves CHD baths. So it's important to educate the patients the same way we would educate staff on how and when to use that CHD soap. There was also an unexplored element of the nursing perspective. If I were to replicate this project, I would like to explore input and experience of nurses and their interpretation of the project. I would like to examine qualitative data about variables that they thought would affect CHD bathing compliance, and this could include nurse to patient staff ratios, availability of supplies, whether this be the linens needed to complete baths, the availability of the CHD soap, the availability of the bathing basins that are needed to give bed baths. There's many variables that I may not even be aware of that the nurses were facing at the time of the study. Again, patients could be off unit for patient testing, procedures, a number of different reasons that they would be unavailable for bathing at the time that the nurse was available to help them bathe, and also patient refusals. Chart audits may also help to identify if any particular nurses were consistently either not documenting that they were giving baths, or if they were consistently not able to complete baths in a timely manner during their shift. These nurses may have benefited from some initial education and then re-education and coaching from leadership on their unit. In conclusion, pre-intervention data without a structured shift huddle showed that with 1,240 patient bathing opportunities, there were 952 baths completed, which was a 76.77% CHD bathing compliance rate. Post-intervention with a structured shift huddle in place saw bathing opportunities of 2,210 with 1,739 baths completed, which provided a rate of 78.69% of daily CHD bathing compliance. There was a low achieved power to the study, which was 0.3669, and this could have been improved with a longer data collection time and a larger sample size. The project can conclude that structured shift huddle did increase CHD bathing, though that finding was not statistically significant. There was inconclusive data if CHD bathing rates impacted the occurrence of CLABSI and CAUTI for this unit. Replicated studies should be longer in data collection time. There should be a larger patient population or larger patient bathing opportunities, and a more thorough investigation of CHD bathing knowledge of both healthcare providers and patients. Baseline knowledge of providers and patients can increase by initial education and re-education, and that may in turn help increase rates of daily CHD bathing. If there are any further questions, please feel free to contact me. And these are my provided references that I used for literature review and to support my structured shift huddle creation and the aims behind this project. Thank you for watching. I appreciate it.